So at the outset, I hope that the video and the screens are clear and the audio is also clear. Yes, Dr. Nitin, can you confirm?
Yes, absolutely clear.
All right. Thank you so much. So my sincere gratitude to Dr. Nitin Chawla for giving me this opportunity and making me a part of this series. I believe there have been more than 110 lectures so far, and I'm really overwhelmed to be associated with this wonderful program. So without a very big introduction, I'll just start with the objective of today's discussion. So we are going to discuss something about persistent pulmonary hypertension in newborns. I'm Dr. Aparna, and I take care of the neonatal ICU services at KIMS Cuddles in Hyderabad. The objectives of this presentation would be to discuss one, we shall be discussing the differences between fetal and neonatal cardiovascular physiology. So we will discuss how the fetal or embryonic circulation is different from the postnatal circulation. We shall then discuss something about the etiology, the risk factors and pathophysiology for persistent pulmonary hypertension in neonates. We shall then discuss an approach to the diagnosis. So how do we make the diagnosis of PPHN, or rather even before that, how do we suspect that a newborn has PPHN? And we should also be discussing the principles of managing PPHN, and we shall be specifically discussing some pharmacological agents such as inhaled nitric oxide and sildenafil a little bit more in detail. So let me begin with this diagram with this figure on fetal cardiovascular physiology. So let me just stop sharing my video for better clarity of the presentation. So let's imagine we'll begin with this small circular, this ball moving up from the placenta. So we all know that oxygenated blood is carried from the placenta through the umbilical vein, and from the umbilical vein through the ductus venosus into the inferior vena cava into the right heart. Now the ball moved in a little quickly, but you'd have appreciated that from the right atrium, the patent foramen ovale actually shunts this oxygenated blood right to left into the left atrium. Now, of course, in the right atrium, the oxygenated blood from the placenta also happens to get mixed with the deoxygenated blood coming from the upper and lower half of the fetal tissues through the superior as well as the inferior vena cava. But through different valves, the oxygenated blood from the placenta is kind of selectively shunted into the left atrium, whereas most of the deoxygenated blood from the tissues, the upper as well as lower half of the body, end up moving through the tricuspid valve into the right ventricle. So moving on, the blood, the oxygenated blood from the placenta, which reaches the left atrium, as well as the small fraction of blood coming back from the lungs through the pulmonary veins, both reach the left ventricle through the left atrium. Then we know that the blood from the left ventricle is pumped into the aorta, and this reaches the rest of the body. And concurrently, let's see what is happening to the blood returning from the fetal tissues. So this blood collected from both the upper and the lower halves of the body through the SVC and the IVC respectively tends to get selectively, driven towards the right ventricle through the tricuspid valve. And of course, in the right atrium, it mixes with the oxygenated blood coming from the placenta. And from here, from the RV, it is pushed into to the pulmonary artery. Now here, by virtue of the increased pulmonary vascular resistance in fetal circulation, which is in turn because of the non-compliant lungs or the fluid-filled alveoli, which limit the vasodilatation of the pulmonary vessels, and this resulting in high increased pulmonary vascular resistance, we know that most of the blood, instead of going into the lungs, they are driven into the systemic circulation or into the aorta through the patent ductus arteriosus. So we have seen actually 3 different shunts operational so far. The ductus venosus was carrying blood from the umbilical vein into the IVC. Then we saw how the patent foramen ovale drives the oxygenated blood from the RA into the LA, and then the third shunt, the transductal shunt, actually shunts the oxygenated, deoxygenated mixed blood coming from the right ventricle into the aorta because of the high pulmonary vascular resistance in the babies in the fetal lungs. So this ultimately reaches the aorta, and then the mix of the oxygenated blood from the right ventricle and the deoxygenated blood from the left ventricle then goes to the selectively to the lower half of the body. So you can see how the upper half of the body receives relatively oxygenated blood from the arch of the aorta, which in turn is carried through these vessels, the brachiocephalic, internal carotid, and the subclavian vessels. And the lower half of the body receives mixed blood coming from both the left ventricle and the right ventricle as a result of the right to left shunt across the PDA. So this is the fetal circulation. Now, after birth, once the baby takes the first breath and the lungs, the alveoli are filled with oxygen-enriched air that the baby breathes in, we know that almost within the first few minutes, there is a very rapid fall in the pulmonary vascular resistance because of the sudden increase in the PaO2, resulting in pulmonary vasodilatation. Hence, the PVR decreases rapidly. Concurrently, the PDA also starts shrinking because of the changes in the oxygenation and because of the constriction of the muscularis propria layer within the ductus. And we also see the closure of the patent foramen ovale because of the progressive increase in the systemic vascular resistance, because of the removal of the low resistance placenta, and because of the left ventricle subserving into the relatively higher resistance of the systemic vessels. So what happens? So soon after the baby is born, the baby takes the first breath. This is given that everything goes well, and the pediatrician would come and do cord clamping. And these days, you all know that we do delayed cord clamping after 60 seconds of the baby's birth. Nevertheless, the cord is clamped and cut, and this removes the low resistance placenta from the systemic circulation. So soon after this happens, the venous return from the lower half of the body goes through the IVC, and the upper half of the body in turn comes in through the SVC, and this reaches the right atrium. And now, because of the closure of the patent foramen ovale, all this deoxygenated blood from the tissues are carried into the right ventricle, and from the right ventricle into the pulmonary artery. Subsequent to the first breath, there is progressive increase in oxygenation, and this results in pulmonary vasodilatation and decrease in pulmonary vascular resistance. And hence, most of the blood from the pulmonary artery now flows into the lungs. So once the blood flows through the alveoli, it gets oxygenated because now the alveoli are more and more filled with oxygen-replete gas from the atmosphere. Or if the baby requires some additional ventilation, then we as clinicians would be providing positive pressure ventilation. This also enriches the alveoli with oxygen-replete gas, and hence this oxygenated blood with a higher PaO2 returns back through the pulmonary veins into the LA, and from there on to the left ventricle, and is carried by the aorta into the tissues. So what are the primary differences in the physiology between the fetal and the neonatal circulation? In the fetus, we saw how the placenta is the organ of the gas exchange, whereas in the newborn baby, the lung becomes the primary organ for gas exchange. In the fetus, the suprasystemic pulmonary vascular pressure was primarily due to the collapsed alveoli or the fluid-filled alveoli, which did not have enough oxygen. Whereas after the newborn baby takes the first breath, the alveoli get enriched with oxygen, and hence the pulmonary vascular pressure decreases and more blood enters the lungs. So in the fetus, the pulmonary blood flow from the pulmonary artery to the lungs is less than 10%, and most of the blood is shunted across the ductus, right to left, to enter the aorta. Whereas in the newborn, in the first few minutes, the pulmonary blood flow rapidly increases. Of course, the fetus is able to survive with this deoxygenated blood flowing in from the aorta because of the relatively low oxygen consumption, because the fetus is dependent on the placenta for most of its metabolism. So the average aortic saturation in the fetus is just as low as 45%. And the fetus is able to survive in this condition, in this relatively hypoxic environment because of the low oxygen consumption. Whereas in the neonate, the placenta is snapped off from the baby and hence the oxygen consumption increases. In the fetus, we discussed about the three shunts operating at the level of the ductus venosus, which carries blood from the umbilical vein to the inferior vena cava, the PFO, which shunts blood from the right atrium to the right ventricle, and of course the ductus itself, and all these shunts start closing one by one in the neonate. So the fetus essentially functions as a parallel circulation, wherein the left ventricle predominantly supplies the the circulation to the upper half of the body is taken by the left ventricle, and the right ventricle tends to subserve to the lower half of the body. Whereas in the neonatal circulation, the circulation becomes a series circulation and both the ventricles have the same cardiac output. So what happens when this transition goes wrong? So there comes in this important neonatal problem of PPHN, or persistent pulmonary hypertension, also called as persistent fetal circulation. So imagine what happens if the neonate continue to have the fetal circulation. So this condition was first described in 1969 by Gersony et al. And PPHN, as we know it today, is defined as a failure of the pulmonary vascular resistance to normally decrease post-delivery. So normally when the baby is born, in the first few minutes, the pulmonary blood flow tends to rapidly increase. You can see right from the fetal time to the first few minutes after birth. You can see how the pulmonary arterial pressures tend to come down. The pulmonary vascular resistance tends to come down. So from around 60 millimeters of mercury to something like 40 millimeters of mercury. This is only by around 30 minutes of life. Of course, it further comes down in the first 48 to 72 hours of life. And it continues to fall in the first few weeks to the physiological levels to less than maybe 15 to 20 millimeters of mercury. And pulmonary blood flow tends to rapidly increase in the first few minutes of life, as you can see here, to almost 4 to 5 times of the fetal levels. The systemic arterial pressure also tends to increase marginally after birth, and this is because of the removal of the low resistance placental circulation from the systemic side. Now, these changes fail to happen in some cases, which is either due to one of these mechanisms. One is the presence of pulmonary vasospasm. So the pulmonary vessels can remain constricted post-birth because of hypoxia, because of acidosis, because of the presence of elevated levels of inflammatory cytokines. There can be a condition of altered pulmonary vascular reactivity where the pulmonary vessels are exceedingly reactive or sensitive to these constricting stimuli. And there may sometimes be increased muscle mass in pulmonary vascular bed due to remodeling or the presence of irreversible structural changes in the pulmonary vessels because of various reasons, including the presence of high increased pulmonary blood flow for a long duration of time. So these changes result in the following aberrations in the circulation, in the postnatal circulation. So once there is failure of the pulmonary vascular resistance to fall, we continue to see right to left shunt across the shunts, the ductus arteriosus and the foramen ovale. So the pulmonary blood flow, instead of directly flowing into the lungs, the flow from the ductus can continue to happen in the right to left direction, resulting in shunting of blood from the pulmonary artery into the aorta. One may also see the increase in the right ventricular afterload, which leads to displacement of the ventricular septum into the left ventricle. So there can be the presence of a D-shaped septum due to the displacement of the ventricular septum into the left ventricle, and this is because of massive afterload on the right ventricle and right ventricular either concentric hypertrophy or dilatation. Ultimately, all these changes can lead to right ventricular failure as well. And in essence, all these changes can lead to tissue hypoxia and multi-organ failure. And we must remember that we must be able to demonstrate the presence of hypoxia in the absence of any other alternative explanation, particularly a cyanotic congenital heart disease. And hypoxia, although may be well tolerated by the fetus, may not be well tolerated by the newborn, and hence this can result in decreased blood flow to the vital organs and multi-organ dysfunction, and with varied symptomatology varying from mild respiratory distress to severe hypoxic respiratory failure needing ICU care. So while we discussed about the failure of the pulmonary vascular resistance to decrease, we spoke about pulmonary vasospasm, altered reactivity, and muscularization leading to remodeling of the pulmonary vessels. So one must know what are the normal stimuli for vasoconstriction as well as vasodilatation of the pulmonary vessels. So some of the important pulmonary vasodilators include oxygen itself. So the increase in PaO2 after the baby's birth is one of the most important pulmonary vasodilators, which results in fall in the PVR. Likewise, alkalosis or increased pH, nitric oxide, prostacyclin or PGI2, bradykinin, and adenosine. So these are all some of the factors that would lead to pulmonary vasodilatation. In contrast, PaO2, which is low, that is hypoxia or hypoxemia, presence of metabolic acidosis or decreased pH, increased levels of endothelin, prostaglandin F2 alpha, leukotrienes, and thromboxane. These are some of the important pulmonary vasoconstrictors. So let's see the role of some of the inflammatory mediators that we just discussed in PPHN, and this in turn will help us to understand the mechanisms of action of some of the drugs used in PPHN. So like we discussed, the endothelial cell, the pulmonary endothelial cell has these levels of the endothelial nitric oxide synthase, which help in production of nitric oxide per se. And nitric oxide, we shall be discussing a little bit more in detail, is an inducer of soluble guanylyl cyclase, an enzyme that kind of converts GTP into cyclic GMP, which in turn is a powerful vasodilator. It's a smooth muscle relaxant. Now, in turn, if you use nitric oxide, you will induce the levels of cyclic GMP, resulting in smooth muscle relaxation, whereas vasoconstrictors such as endothelin would work through the endothelin receptors. We have endothelin receptors A as well as B, and these can in turn result in vasoconstriction and vasodilatation respectively. So endothelin A results in smooth muscle vasoconstriction, whereas endothelin B in turn can result in induction of the endothelial nitric oxide synthase enzyme. Now, on the other hand, the cyclic GMP that is normally produced in the cell tends to get degraded by phosphodiesterases, and inhibition of phosphodiesterase 5 by the drug sildenafil also results in increase in the levels of cyclic GMP, again resulting in smooth muscle relaxation. Now, on the other hand, we have prostacyclin or PGI2, which is an inducer of the adenylyl cyclase enzyme, which also results in elevation or production of cyclic AMP, adenosine monophosphate, which also is a smooth muscle relaxant. So both cyclic AMP and cyclic GMP aid in smooth muscle relaxation. So while nitric oxide results in the production of cyclic GMP, prostacyclin, which is also a pulmonary vasodilator, results in increasing the level of the other smooth muscle vasodilator, which is cyclic AMP. Now, once again, phosphodiesterase 3 is something that degrades cyclic AMP back to AMP, and this is inhibited by milrinone. So milrinone also is used as one of the pulmonary vasodilators because of the inhibition of the enzyme that degrades cyclic AMP, which is a smooth muscle relaxant. So on the other hand, on the one hand, we have sildenafil, which is a phosphodiesterase 5 inhibitor, and on this hand, we have milrinone, which is a phosphodiesterase 3 inhibitor, both resulting in pulmonary vasodilatation. So the second part of the talk would be focusing on the etiology and various risk factors and pathophysiology of PPHN. So we have so far discussed about the transition from the fetal to neonatal circulation. We have discussed some of the factors that are associated with pulmonary vasodilatation and vasoconstriction, and we have also seen something about the molecular mechanism for PPHN involving various inflammatory cytokines. Now we shall be discussing about the different reasons that we see PPHN in newborns. So one of the most important group of causes is secondary PPHN due to severe parenchymal lung diseases, which can vary from meconium aspiration syndrome or hyaline membrane disease or RDS in a preterm baby, and lung infections such as pneumonia or sepsis. The second most important group of causes is hypoxia secondary to either birth asphyxia at birth or postnatal hypoxia, like a sudden hypoxic event or hypoxia secondary to postnatally acquired infections can also trigger severe PPHN. Congenital lung diseases, particularly congenital diaphragmatic hernia and large cystic adenomatoid lung malformations per se, can also lead to PPHN because of decrease in gas exchange and also decrease in the pulmonary vascular surface area, which in turn can lead to increased PVR. And once we have dealt with this huge list of secondary PPHN, we are left with something called as idiopathic or primary PPHN, which is genetic in etiology, where you may not find any other associated pulmonary parenchymal lung disease. So a newborn who may have any of these parenchymal conditions, either increased retained lung fluid or transient tachypnea, pneumonia, respiratory distress syndrome in preterm is the commonest cause for PPHN, meconium aspiration syndrome, or the presence of large pulmonary air leaks can have, decreased impaired gas exchange, hypoxia, and acidosis, which can in turn trigger the cycle of pulmonary vasoconstriction and PPHN. On the other hand, you can have lung malformations such as this one, diaphragmatic hernia, where you have massive herniation of the intestine, the bowel loops into the chest, and compression of the lung resulting in pulmonary hypoplasia and PPHN. We may also see PPHN secondary to maternal drugs such as selective serotonin reuptake inhibitors, SSRIs, and NSAIDs related to PPHN. And of course, birth asphyxia with hypoxia and acidosis itself can cause PPHN. And once PPHN sets in, we start seeing abnormal right to left shunts across the PFO, across the PDA, resulting in hypoxia to all the different organs, and right to left shunt across the PDA as well. So what happens when, the baby does develop PPHN? So we start seeing, and remember here in this diagram, the atrium is located inferiorly and the ventricles are located superiorly. So we start seeing elevated pulmonary vascular resistance, which in turn leads to elevated pulmonary artery systolic pressures and right ventricular systolic pressures. This in turn can lead to tricuspid regurgitation and right to left shunt across the PFO as well as the PDA. Very often can be shunting either bidirectionally or predominantly right to left. So this would lead to shunting of the deoxygenated blood from the pulmonary artery into the aorta post the subclavian artery, or sometimes the duct may be located between the carotid and the subclavian artery. So resulting in difference between the saturations in the right upper limb and the either feet, which represent the postductal circulation. So there is a difference in the pre and the postductal saturations, pre and the postductal PA mode. So the lower half of the body tends to get deoxygenated blood, especially when the PDA is patent. Of course, when the PDA is no longer patent, the shunting predominantly happens at the level of the PFO, and you may see that the saturations may be uniformly low in all the four limbs. Within the lung, of course, the pulmonary vascular resistance is significantly elevated, which is leading to a compromise in the pulmonary blood flow. And provided ventilation is reasonably preserved, there would be significant VQ mismatch, and VQ mismatch can also be secondary to parenchymal lung disease, leading to reduced ventilation. So this can be particularly complicated in cases of diaphragmatic hernia, where there can be significant compromise of the pulmonary volume available, the pulmonary alveolar branching, as well as the pulmonary vascular surface area, leading to significant elevation in the pulmonary vascular resistance. And if you look at the breakup of causes, etiology for PPHN overall, around a fourth of all cases of PPHN tend to be associated with idiopathic or primary PPHN, where there is no associated parenchymal disease, whereas up to 42% of cases of PPHN can be related to meconium aspiration syndrome. Up to a fifth of PPHN can be related to RDS, and RDS tends to be the commonest cause of PPHN in the preterm population. The rest of the cases are usually secondary to congenital or acquired infections, pneumonia, and lung hyperplasia as a sequel to oligohydramnios or as a sequel to associated malformations like diaphragmatic hernia. And the overall incidence of PPHN tends to be something like 2 per 1,000 live births, or 0.2%. So while we take meconium aspiration in particular, because this is the commonest cause for PPHN in general, we know that meconium tends to cause inflammation due to release of pro-inflammatory cytokines like TNF-alpha, interleukin-1 and 8, and it inactivates endogenous surfactant and causes severe inflammatory reaction or chemical pneumonitis with airway obstruction due to the presence of meconium plug per se, or partial obstruction with a ball valve effect. All these four mechanisms, obstruction, chemical pneumonitis, inflammation, surfactant inactivation, and cytokine storm, result in inadequate ventilation in the immediate postnatal phase, impaired VQ match or VQ mismatch, leading to pulmonary vascular vasoconstriction, leading to PPHN. Whereas in birth asphyxia, PPHN is driven by pulmonary vasoconstriction due to release of humoral factors, and in chronic hypoxia, there tends to be extensive remodeling and abnormal muscularization of the pulmonary arteries, again leading to increase in pulmonary vascular resistance. In idiopathic or primary PPHN, PPHN tends to be secondary to biological or genetic susceptibility due to mutations in the bone morphogenic receptors, or closure of PDA due to maternal NSAID exposure. Sometimes this history may not be evidently elicitable, and we end up classifying some of these NSAID secondary PPHNs as idiopathic PPHN, and it could sometimes be due to reactive oxygen species, particularly superoxide and hydrogen peroxide. And these mechanisms in turn can lead to pulmonary vascular remodeling, vessel thickening, and smooth muscle hyperplasia. In CVH, as we already discussed, there is pulmonary hyperplasia associated with pulmonary vascular surface area being lesser due to a decrease in the effective pulmonary vascular cross-sectional surface, which is available due to decreased branching of the pulmonary vessels. And this may also happen with alveolar capillary dysplasia. So far we have discussed the pathogenesis, the various risk factors, and etiology for PPHN. Now we are going to move to the clinical domain. So as a clinician, how do you suspect and confirm that your baby has PPHN? So PPHN, we know, is a disease that affects term and post-term infants predominantly, and rarely in preterm infants with severe RDS, you may also see PPHN. On examination, the baby tends to have hypoxia, and we know that when hypoxia results in significantly decreased saturations, with saturations dropping to less than 85–80%, we start seeing clinically overt cyanosis. There is respiratory distress, which may depend on the severity of the underlying parenchymal disease. Of course, with idiopathic PPHN, one may not find significant respiratory distress, but this is very relatively rare. One tends to see, even in secondary PPHN, secondary to parenchymal diseases, that hypoxia may be out of proportion to the symptoms of parenchymal involvement. So you may have more severe hypoxia and lability of saturations, which may kind of be more predominant over the signs such as tachypnea, retractions, and increased work of breathing. The baby may also have a prominent right ventricular impulse because of right ventricular hypertrophy. So there may be a prominent precordial impulse. And very, very importantly, if there is an associated PDA, the important finding that you're likely to see is a difference in the pre-postductal saturation. So there will be a gradient of at least 5% or more between the saturations from the right upper limb and the saturations recorded in either foot. Now, generally, conventionally, pre-ductal saturations are measured from the right upper limb and post-ductal saturations from either foot because of the variability of the location of the vessel supplying the left upper limb. So your PDA can sometimes be may precede the left subclavian artery, may sometimes be follow the left subclavian artery. So typically the left upper limb is kind of controversial and is not included into the consideration of pre-postductal. So if you find the right upper limb saturation at least 5% more than the SpO2 recorded in either foot, you start suspecting whether this could be PPHN. And one may also sometimes appreciate the systolic murmur of tricuspid regurgitation. So having clinically suspected PPHN based on the presence of oxygen lability, hypoxia out of proportion to the signs of respiratory distress, the presence of pre-postductal saturation difference of at least 5%, and additional signs which may or may not be present, such as a prominent precordial impulse and the presence of a systolic murmur of TR. Let us now discuss something about few important investigations. Hyperoxia test has probably become very primitive and is now probably more and more limited to our textbooks, but probably for the sake of completion, I thought we should discuss this. So this is performed by taking arterial PaO2 recordings, of course, before doing the test, or one baseline PaO2 followed by providing at least 15 minutes of 100% oxygen to the baby. Now, this can be provided by increasing the FiO2 if the baby is on respiratory support. And if the baby is not on CPAP or ventilation, then one can provide a flow of more than 5 to 6 times of the minute ventilation. So a flow of more than 6 liters per minute through a hood, which can be provided with a tight seal so that all the portholes may be closed, and this can be allowed to remain on the baby for at least 15 minutes before a repeat PaO2 is done. So 2 arterial PaO2 readings are taken, one before performing the test and one after giving 100% oxygen for at least 15 minutes. If the arterial PaO2 has increased to well above 250 millimeters of mercury post this test, this is generally suggestive of a parenchymal lung disease, and the baby is said to have passed the hyperoxia test. If the arterial PaO2 post-hyperoxia still remains less than 100 millimeters of mercury, then this is strongly suggestive of a cyanotic congenital heart disease, which could either be transposition physiology or TOF physiology, tetralogy physiology. So either there could be increased pulmonary blood flow or decreased pulmonary blood flow. Now, if the arterial PaO2 is equivocal, which is 100 to 250 millimeters of mercury post-hyperoxia test, then we may be either dealing with an admixture lesion, or sometimes you may also see this in cases of persistent pulmonary hypertension of newborn. Now, regarding the other investigations, the chest X-ray in PPHN is fairly non-specific because it depends upon the underlying etiology. So it can vary from a normal chest X-ray in idiopathic PPHN to the presence of evidence of the associated condition. Say you may find herniation of the intestinal loops on the left side of the hemithorax in CDH. You may see ground glass appearance if it is RDS. One might see extensive hyperinflation with coarse nodular opacities and increased lung volume if we are dealing with meconium aspiration syndrome. And in ECG, one might see right ventricular hypertrophy with ST segment depression because of the increased right ventricular afterload. So this is an X-ray showing a classical diaphragmatic hernia, left-sided, and likely Bogdalek hernia. You can see that the left hemithorax is completely occupied with gas-filled intestinal loops, and there is also significant shift of the mediastinum to the right side, and this tends to be associated with not only ipsilateral but sometimes contralateral pulmonary hyperplasia. This is another case of a term baby with PPHN secondary to meconium aspiration syndrome, wherein you can appreciate that the lungs are hyperinflated both sides, and there is the presence of inhomogeneous and bilateral opacities, coarse opacities involving both lungs, and the presence of hyperinflation and few cystic changes in the right lower lobe, indicative of likely meconium aspiration syndrome. On the other hand, this is a baby with PPHN who came with severe hypoxic respiratory failure with relatively normal looking lung parenchyma. You can see that there is bilateral, almost black lungs here with minimal parenchymal infiltrates and opacities. And this is a classical case of idiopathic PPHN, wherein there is no underlying parenchymal lung disease. This is a baby who presented with PPHN on day 5 of life, secondary to other clinical features of infection such as temperature instability, sepsis, prolonged CRT with multiple apneas, episodes of apnea. And this is a classical case of bilateral bronchopneumonia. So once we have ascertained or suspected a diagnosis of PPHN based on the clinical signs and based on the X-ray and of course ECG is something which is grossly underperformed investigation, you may or may not even do the hyperoxia test. Most of us straight away embark on the echocardiography whenever we suspect PPHN in order to confirm the diagnosis. So how does echo help us in ascertaining the presence of PPHN? So the presence of right to left shunt across the patent ductus arteriosus as well as the foramen ovale is kind of an evidence of increased pulmonary vascular resistance and increased right-sided pressures. Basically, this shows that the pulmonary pressures are suprasystemic. The presence of prolonged systolic acceleration time and a flat or a bowed septum towards the left side is also an evidence of increased right ventricular pressures, along with the presence of signs of right ventricular hypertrophy and tricuspid regurgitation. So I'll try to show you some of the echocardiographic images. So this is a kind of apical 4-chamber view. This is in 2D echocardiogram, and this is with color Doppler. And you can appreciate that this is the RA, the RV, and the left atrium and the left ventricle and the tricuspid valve. And whenever there is a significant tricuspid regurgitation, you tend to see this blue jet. So this indicates that there is flow of blood away from the probe. So this is blood flowing from the right ventricle towards the right atrium. And this is because of the elevated right ventricular pressures as well as secondary dilatation of the tricuspid area. So the presence of tricuspid regurgitation shows that there is likely elevated right ventricular peak pressures. Of course, this may be sometimes absent when right ventricular function is severely compromised. So the tricuspid regurgitation is not absolutely sensitive for the diagnosis of PPHN. We also tend to appreciate the presence of the right to left shunt across the two important shunts that we look for in the echo include the ductal shunt as well as the transatrial shunt. And right to left shunt across these two shunts is also indicative of PPHN. So this is an important sort of figure which helps us to sort of say whether we are dealing with PPHN or similar conditions such as duct-dependent congenital critical cyanotic heart disease based on the direction of the transatrial and the transductal shunt. So for most of us who are non-cardiologists, the detailed assessment of the structural aspects of the heart may be something which is out of our regular expertise. But most of us would be able to appreciate the direction of shunt across the atria, the atrial septal defect or the PFO, and across the PDA. So this information can itself be of great help. And as we can see in these 4 figures, and we'll go through them, can give us a very important clue about what may be the likely etiology for hypoxia that we are dealing with. So in classical PPHN, which as we all know is the presence of increased right-sided pressures, usually resulting in extrapulmonary right to left shunt or intracardiac, extrapulmonary right to left shunt is the right word. So you tend to see right to left shunt both across the PFO as well as the PDA. The treatment of PPHN we will be discussing a little later would involve the recruitment of the lung to the maximum FRC as well as the use of pulmonary vasodilators. Now, on the other hand, if you were to see right to left shunt across the transatrial shunt and a left-right shunt across the ductus. Now, this is a very different, unusual situation, and this may be indicative of a duct-dependent pulmonary circulation. So, typically, if you have a duct-dependent pulmonary circulation, so this is something that we usually come across if there is pulmonary atresia, critical pulmonary stenosis, or tricuspid atresia. You would actually see that the pulmonary circulation is dependent on the left to right shunt across the duct. So here you would still find right to left shunt across the atrium because of the obstruction lower down in the form of tricuspid atresia or pulmonary atresia, but there wouldn't be a right to left shunt across the ductus. So if we find this picture, then the treatment would not be nitric oxide and sildenafil. The treatment would be measures to keep the duct patent. And of course, we get confirmation by a cardiologist performed echo. A hyperoxia test would obviously fail in this condition. So we would start prostaglandin to keep the duct patent in order to keep the pulmonary circulation flowing. Now, if we were to find left to right shunt across both the transatrial as well as the ductal shunts, why do we still have hypoxia? So then obviously, the reason for hypoxia is from the parenchymal part and not really because of the extraparenchymal, extrapulmonary shunts. The direction of shunt in a normal person also would be left to right across both the PFO and the PDA. So here one would treat hypoxia like one would treat any other parenchymal disease. So look into the X-ray, try to address the etiology for hypoxia specifically, such as using surfactant in RDS or recruiting the lung if you're dealing with meconium aspiration syndrome, or maybe use antibiotics if you're suspecting or dealing with congenital pneumonia, or management of pulmonary hypoplasia in CDH, etc. Now, lastly, if you were to find a left to right shunt across the atrial septal defect, across the PFO, and a right to left shunt across the ductus, this is indicative of severe left ventricle dysfunction. So it's very unusual to have a normal left to right shunt across the ASD and a right to left across the PDA. And this only happens if there is RV dependent systemic circulation. So if the systemic circulation from the LV to the aorta is not optimal, and the PDA is actually shunting some circulation into the systemic circuit from the right ventricle, and here inhaled nitric oxide actually can be very detrimental, because it can actually worsen the pulmonary venous hypertension. It can clog the left atrium more and more. It can increase the left atrial pressure, and it can also compromise the systemic blood flow by selectively shunting blood into the lungs. So this is one condition where if you start nitric oxide, the baby may actually start worsening, where there is a severe left ventricular dysfunction with pulmonary venous hypertension. Here, so one should start an inotrope and try to optimize the left ventricular contractility, improve the systemic blood flow before we think of measures to reduce the pulmonary vascular resistance. So coming to the management of PPHN per se. So the management of PPHN centers primarily on prevention. So PPHN is often secondary to severe parenchymal lung diseases. So anything that prevents severe parenchymal lung diseases, such as giving antenatal steroids to prevent RDS, antenatal diagnosis of CDH, so prompt prevention or treatment of infections, infective etiology for PPHN, congenital pneumonias, and prevention and management of acidosis, hypoxia, poor perfusion. All these are important aspects of preventing PPHN per se. A lot of focus is to be laid on prevention of hypothermia, which again is a powerful pulmonary vasoconstrictor. Wherever possible, try to avoid 100% oxygen. Although hypoxia may be an important factor associated with PPHN, it has also been seen that reactive oxygen species can generate superoxides and hydrogen peroxide, which can also increase pulmonary vasoconstriction. So avoid using 100% oxygen for the treatment or for the prevention of PPHN. Of course, early diagnosis and referral can save a lot of lives and can save a lot of time delay in the initiation of appropriate therapy. Coming to the delivery room management, so when one anticipates that there could be PPHN, particularly in a case of CDH, what does one do? So you work around optimally recruiting the lung by using optimal delivery room PEEP with a TP's resuscitator wherever appropriate. Follow the NRP guidelines. Try to establish optimal ventilation within the first golden minute, targeting a saturation limit which is based on the minute-specific saturation targets laid down by the NRP, remembering that it takes 10 minutes for a baby to normally saturate between 85 to 95%. Prevent hypothermia, target preductal saturations as we discussed, minute-specific, and remember that high oxygenation also can decrease the responses to nitric oxide later on. Now, supportive measures in PPHN play a very, very important part and probably are more or at least as equally important as pharmacological measures are, which include optimizing all the normal parameters. So optimize all the vital signs when you're dealing with PPHN. Optimize temperature between 36.5 to 37.5 Celsius. Optimize the blood glucose, blood calcium, the blood pH levels, the hematocrit. Optimize nutrition by providing appropriate calories, either enterally if possible, or if not possible, parenterally. Avoid stress, avoid nociceptive stimuli by preventing pain, preventing loud light, loud noise, and try to use analgesia whenever procedures have to be performed, even if it is urinary catheterization or endotracheal suctioning, although try to avoid paralysis because this can decrease the systemic blood pressures and can worsen right to left shunt. So, although there is a role for maintaining normal pH between 7.3 to 7.4, there is actually no role for hyperventilation. And in fact, it can be detrimental to actually increase the pH to more than 7.45. Although one should try to maintain the pH within the normal limits, which includes normal PaCO2 as well as normal PaO2. Try to optimize oxygenation by means of targeting optimal pre- and postductal saturation. Now, when it comes to the saturation targeting, one has to remember that the preductal sats are directly linked with the circulation of the lungs and the eye, and thereby one should target the normal range of 90 to 95%. Postductal saturation, it may be, of course, a little daring to target as low as 70 to 80%, but one could accept relatively low postductal saturation for the want of avoiding more and more lung injury, provided the baby is perfused well, making urine and lactates are less than 3. And target PaO2 within the normal range of 55 to 80 millimeters of mercury. Remember, hyperoxia also will subsequently increase free radical injury and desensitize the lung to nitric oxide. Maintain optimal cardiac output and perfusion by optimizing the left ventricular function. We'll just be seeing a small flow chart in a minute. This includes optimizing both the volume. Optimize the volume by using fluid boluses judicially if there is evidence of decreased intravascular volume. And if volume has been optimized, then go on to optimize the systemic blood pressure by using vasoconstrictors appropriately. Now, if there is an underlying cause like pneumonia and MAS or RDS, of course, one has to use appropriate specific management, including surfactant, surfactant for RDS, and in some cases for meconium as well, and appropriate IV antibiotic therapy. When it comes to the ventilatory strategies in PPHN, one has to focus on optimizing lung recruitment. We all work on the open lung strategy, these days. This involves optimizing the PEEP in order to achieve a lung expansion of 8 to 9 posterior intercostal spaces and trying to limit the peak inflation pressure, the tidal volumes, which are the more deleterious factors in ventilation, and accepting certain degree of hypercapnia. If the neonate requires further increase in pressures, including a PIP of more than 26 or MAPS more than 14 to 15, consider switching to high frequency ventilation. So this picture summarizes the various aspects of managing PPHN. Now, in addition to the specific management for the underlying lung disease, the primary focus in PPHN in terms of supportive care is to minimize pain, stimulation, providing optimal nutrition, maintaining normal or optimal levels of PaO2 or saturation targeting to be 90 to 95% preductal, and arterial PaCO2s of 45 to 55, max 60 millimeters of mercury, optimizing the blood volume, perfusion as measured by normotension, normal urine output, and lactates less than 3 millimoles per liter with a pH of more than 7.25 to 7.3. Now, all this, if in place, one will start seeing that the pre-postnatral saturation difference starts falling to less than 5%, and the echocardiographic evidence of PPHN may also start showing optimization of the different signs, echocardiographic signs of PPHN. Now, coming to the hemodynamic support, as we discussed, the echocardiography generally is useful to assess and confirm the presence of PPHN and also to rule out associated structural heart disease. So, in terms of ventilation, we try to recruit the lung with optimal PEEP and optimal airway pressure, mean airway pressure without the specific management. If the newborn has normal blood pressures with adequate cardiac function, then one continues with appropriate ventilation strategies and focusing to avoid both hypoxia and hyperoxia. And one can start nitric oxide. We will discuss that in a moment. If the oxygenation index crosses 15 to 20. Now, if the newborn in turn has normal blood pressure with cardiac dysfunction, consider using inodilators such as milrinone. If the newborn has low blood pressure with good cardiac function, then one has to focus on improving the MAP, the mean arterial pressure, by using fluid boluses judiciously, up to 2 boluses of 10 ml per kg of crystalloid, and followed by a vasoconstrictor such as dopamine or norepinephrine or vasopressin. We generally start with a dopamine at a dose of around 10 mics per kg per minute. Low dose dopamine has no role. And one could add an additional vasoconstrictor such as epinephrine at doses more than equal to 0.3 micrograms per kg per minute, or norepinephrine. And in more severely hypotensive cases, vasopressin, and concurrently optimizing the pH, oxygenation, and PaCO2 levels, and consider hydrocortisone when the requirement of inotropes typically crosses more than 20 mics per kg per minute of dopamine. When you have to add norepinephrine or epinephrine, do consider whether one needs to use a dose of hydrocortisone. And if the newborn has both low blood pressure with cardiac dysfunction with rapid deterioration, this may be a case where in multiple inotrope failure, one may have to think of extracorporeal membrane oxygenation. So coming to specific treatment of INO, and I think I'm running out of time, specific treatment of PPHN with nitric oxide. We know that inhaled nitric oxide activates the guanylyl cyclase enzyme and increases the formation of cyclic GMP, which is a powerful smooth muscle dilator. It also helps in redirecting the blood flow from the poorly aerated lung to better aerated lung, resulting in better VQ match or decreasing the VQ mismatch. And this in turn reduces the intrapulmonary shunting, that is when there is when the perfusion to the relatively non-aerated parts of the lung. This leads to intrapulmonary shunting, which is reduced by nitric oxide. It also is an anti-inflammatory agent and reduces lung inflammation, helps in preserving surfactant, and through all these mechanisms can effectively reduce the pulmonary vascular resistance. So, when you have inhaled nitric oxide therapy, automatically it reaches the well-ventilated alveoli easily, resulting in the selective action of nitric oxide on the pulmonary blood vessels situated proximal to the ventilated alveoli, and this, as you can appreciate, reduces the VQ mismatch. So the non-ventilated alveoli and the pulmonary blood vessels situated around it are less likely to get dilated because of nitric oxide. So this itself is called as a micro-selective effect. And we know that once it reaches the blood vessels, the nitric oxide tends to get actively inactivated by the hemoglobin present within the blood vessels, and hence it has almost nil or minimal systemic vasodilatation. So NO, which has now become popular therapy in PPHN, is considered in newborns more than 34 weeks with hypoxic respiratory failure after achieving optimal lung recruitment. And hypoxic respiratory failure is defined as the presence of OI, the product of mean airway pressure into FiO2 divided by post-ductal PaO2, more than 15 to 25 on at least 2 post-ductal arterial blood gases. So if you see, MAP into FiO2 is what you give to achieve oxygenation, and post-ductal PaO2 is what we measure from the baby, what we get. And this product, this ratio into 100 is oxygenation index. And if this is more than 15 or 20 on two blood gases 15 minutes apart, this becomes a classical indication for nitric oxide, in addition to echocardiographic evidence of right to left shunt across the ductus with elevated pulmonary artery pressure, as estimated by the Bernoulli's equation, which in turn depends upon the assessment of the velocity of the TR jet. So the pressure of the RVSP is equivalent to RA pressure plus 4 times of the velocity of the tricuspid jet. So this helps us in calculating the right ventricular systolic pressure, and this in turn is extrapolated into the pulmonary artery systolic pressure. Of course, the third thing that we also need is the absence of concurrent systemic, the cyanotic congenital heart diseases, presence of a pre-postductal saturation difference more than 5%, and more than 2 times decrease in the arterial oxygen saturation to less than 85%, despite optimal treatment of the underlying lung condition or optimal ventilation. And of course, in CDH with suprasystemic pulmonary vascular resistance after establishing optimal lung ventilation. So the focus is always first on recruiting the lung optimally. And despite that, if the baby continues to have hypoxia as evidenced by all these findings, one starts nitric oxide. There are few contraindications, such as the presence of major associated congenital anomalies, where the prognosis may be guarded, and the presence of grade 3, grade 4 IVH, and of course, echo showing an alternative diagnosis in the form of a duct-dependent heart disease, such as hypoplastic left heart or interrupted aortic arch, where nitric oxide can be counterproductive. And of course, as we discussed in the figure that we saw earlier, if there is severe LV dysfunction, nitric oxide can again be counterproductive. So one has to optimize the LV function before starting nitric. You all would have seen the inosis system. You have different dials for setting the flow rate here. You have a coarse as well as a fine flow meter for adjusting the flow of nitric oxide. And based on the ventilator's bias flow, you may require to give something between 150, 160 or 200 mLs per minute in order to deliver the typical dose of 20 ppm. So how does one initiate INO? So we begin using the 20-20-20 rule. One starts INO at an oxygenation index of 20. You know, OI was mapped into FiO2 divided by PaO2 at a dose of 20 again, 20 ppm. And a response is defined as a PO2 by FiO2 ratio of 20 or more after 20 to 30 minutes of starting nitric oxide. So this is a 20-20-20 rule for starting NO, and there is a rule for weaning NO as well, which is the 60-60 rule. So once you reach, while weaning, you start weaning the FiO2 first in steps of maybe 5% every few minutes. And once you reach a FiO2 of less than 60% consistently with a PaO2 of more than 60 mm of mercury, you can think of weaning nitric oxide. So once you begin INO, typically at the dose of 20 ppm, you reassess an ABG typically after 30 minutes. And if the PaO2 has gone up by more than 20% or the oxygenation index has come down by more than 20%, this calls for a 50% reduction in the initial dose. So if you've started from 20, one can come to 10 ppm. We generally go a little bit slower. So from 20, we generally come down to 15 at 6 hours and then come down further to 10 ppm. Now, if this doesn't happen, or if the arterial by alveolar ratio is less than 0.22, then it's called as failure of nitric oxide, and then one can slowly taper and stop nitric oxide completely. Whereas if there is response to nitric oxide as evidenced by an increase in PaO2 at half an hour after initiation, then one starts weaning gradually. At every step, one has to look for any rebound hypoxia as evidenced by more than 20 to 30% increase or fall in the PaO2 after the INO has been tapered down. So if the PaO2 is less than 50, or if the PaO2 fall is more than 20% of the baseline, then one has to actually step up back to the previous dose, or maybe even double up the dose of nitric oxide. So once you reach 5 ppm, then you start weaning even more slowly in steps of 1 ppm until you reach 1, and then discontinue nitric oxide completely. At every step, it is very, very important to look for any rebound increase of the oxygenation index or rebound increase in the FiO2 requirement, or a fall in PaO2 by more than 20% from the baseline. All these indicate failure of weaning of nitric oxide. So Dr. Nitin, if you have another 2 minutes, I'll quickly touch upon the other therapies. So the other therapies that are often used for treating PPHN include sildenafil, which is a vasodilator. The problem being this is a non-selective vasodilator, so it can cause significant systemic vasodilatation and hypotension. The dose is 1 to 3 milligram per kg given every 6 hours. It can be given both intravenously as well as orally. Intravenous is given with a loading dose followed by a maintenance dose of 0.07 milligrams per kg per hour. Consider sildenafil if the oxidation index is touching or crossing 15, particularly in setups where nitric oxide may not be available. Typically, when nitric oxide is available, it is a selective pulmonary vasodilator and it has plenty of advantages over sildenafil. And with sildenafil, one also has to deal with the problem of significant systemic hypotension. So one has to be very cautious with its use. I'll skip this slide because we've already done it. The other pulmonary vasodilators include milrinone, which is a phosphodiesterase 3 inhibitor, which is given with a loading dose of 50 mics per kg, followed by a maintenance dose of 0.3 to 1 mic per kg per hour. This can be very useful in the treatment of PPHN with LV dysfunction. Again, one has to watch for hypotension. The other drug, which is an endothelin receptor antagonist, is bosentan, given at a dose of 1 mg per kg every 12th hourly. This can be tried for 72 hours and tapered slowly, and one has to watch for abnormal liver function. Now, the other therapies are mostly experimental, and most of them have not translated from bench to bedside. These include prostacyclin, prostaglandin E1, and iloprost, which is given either aerosolized or in the intravenous route. So, of course, magnesium sulfate, which is a calcium antagonist and a potent vasodilator, is also often used for the management of PPHN. So, with those words, I'll just quickly spend maybe a few seconds on the long-term outcomes, and then we will summarize whatever we have seen. So the long-term outcomes of newborns with PPHN are not uniformly, reassuring. There is a 20 to 30% risk of neurodevelopmental impairment and hearing impairment, particularly those who have been treated with nitric oxide. So I'll summarize with the following key messages. Suspect PPHN whenever you're dealing with a newborn with labile saturations and with hypoxemia, which is disproportionate or which is more severe than signs of respiratory distress or underlying evidence of parenchymal lung disease. And PPHN is also suspected when there is a difference in the pre-postrectal saturations more than 5% in infants with oxygen lability. Echocardiography remains the preferred modality for confirmation of PPHN. And the important echocardiographic signs include the presence of elevated right ventricular and pulmonary artery systolic pressure, evidence of tricuspid regurgitation, a D-shaped or bent septum towards the left ventricle, and the presence of pulmonary acceleration, peak systolic acceleration times being lesser, and evidence of right to left shunt or bidirectional shunts across the PDA as well as the PFO. Treatment of PPHN is predominantly supportive in the form of reducing pain, maintenance of normal pH, glucose, calcium, PaCO2 and PaO2 levels, optimizing saturations and optimizing all these blood parameters, hematocrit, prevention of anemia as well as polycythemia, and the use of specific pharmacological agents wherever appropriate, the most popular of which remains inhaled nitric oxide. And with other specific therapies such as sildenafil, magnesium sulfate, prostacyclin, bosentan, etc. Prevention is always better than treatment, and this is very true for most conditions in neonates, especially with PPHN. So with those words, I thank all of you for your patient listening, and I shall sort of hand over back to the organizers. Yeah, Dr. Nitin is back.
So I think we all should thank you for making this complicated and still less known topic with so much dedication. You have made it so simple, and I think extensive the question which you have asked me previously, that how much time